I'd like to welcome everybody to today's OCAD lecture, which is being given by my friend and former colleague, Dr. Gregory DiFelice, who's a fellowship-trained orthopedic surgeon with over 20 years of experience specializing in sports traumatology and joint reconstruction surgery at the Hospital for Special Surgery and New York-Presbyterian Hospital. He also holds an academic appointment at the Weill Medical College of Cornell University as an assistant professor. He's a graduate of Princeton University and New Jersey Medical School and did his residency training at HSS and sports medicine fellowship at Washington University in St. Louis. He's a surgical innovator who's developed a concept called ligament preservation. Ligament preservation includes conservative, minimally invasive techniques such as primary repair and primary repair with augmentation. By saving patients' native ligament tissues, he greatly reduces surgical injury to the patient, diminishing the recovery time and restoring more of the natural function of the knee. He's lectured extensively, both domestically and internationally on this topic. Okay, Greg, I'm looking forward to this.
Thanks for the invite, and I'm always happy to share this topic and my research. I find it to be quite fascinating. I hope you will too. You know, it really gets down to why do we do what we do? And is there a better way to do it? And that's kind of what we're all striving and looking for anyways. So the first place I start is this thing we call the ACL. And I always think this is a great anatomic dissection in action that a colleague of mine, Dr. Jorge Chala, did. He allowed me to use his slide, and you can see just how complex that ligament is. It's not a simple structure. It's band-like, and when the knee is in one position, it's cord-like when it's in another. It wraps on itself, and it's really amazing. And our what we do surgically is simply put a tube of collagen in there and hope that it works similarly to this complex structure. And there's definitely limitations to this, and we'll talk more about that. So I want to start off and let you know that I'm biased. I'm going to share with you my research. Obviously, I believe in my research, and so understand that you got to take it with a little bit of grain of salt. I'm not here to tell you what's right and wrong, but I am here to share with you the journey that I've gone over the past 12 years in investigating why we do ACL reconstruction, why we don't do ACL repair, and maybe why we should. So again, why we do what we do. I want to talk with you about what I do, how I do it, and why I do it, and share with you my research. And also, you know, this is really where I think the future of ligament surgery in the knee and, you know, perhaps orthopedic surgery in general is going to be, is more of a biologic approach where we're helping the body to heal rather than replacing parts, so to speak. So this is who I am. I do practice at the Hospital for Special Surgery in New York City. And these are my disclosures. I do work with a company called Arthrex, who makes is one of the largest sports medicine companies in the world, and it's their materials that enable me to do my procedure, and they have graciously supported my research, and I want to let you know that. So it brings me to this slide, which is one that always reminds me that I was taught when I was a resident, as were generations of orthopedic surgeons, that the ACL can't heal because it doesn't have good blood supply. And you can see here from this approximately torn ligament that it has pretty darn good blood supply, as you see the capillary refill. So this is my procedure, which is called primarily repaired ACL with internal brace augmentation. This is the same patient about a year later, and you can see how that ligament has scarred in nicely. And here we are up at the wall probing the femoral origin, and you can see that's healed up quite nicely with my procedure. And I'll show you exactly how I do this. Now remember, that's the native ligament. We have not replaced the ligament with a graft like people normally do. You know, interest in ACL repair was basically nil from the 90s and the 2000s. There's very few articles written. And I published my first article in 2012. and you can see where things have gone. There's quite a lot of interest as people revisit this concept and with a modern day twist. A brief shout out to those before us who started all of the work on ACL primary repair. The first person is Colonel John Fagan from West Point, who worked on the West Point cadets and did open primary repairs back in the day. And then you see some others. There's John Marshall from HSS and Dick Stedman. You see Lanny Johnson. And then eventually you see in the corner here, Mark Sherman. And Mark Sherman's known for his work in the and was known as he wrote the landmark paper on ACL repair, and this was it, and it was published in 1989. And he classified the different tear types, and he had 5-year follow-up on 50 patients. And what he noticed was that, you know, about 80% of the patients did pretty reasonably well, and they had good, excellent results. But he found that the patients who had type 1 tears, which were proximal tears off the bone and excellent tissue quality, usually a skiing mechanism of injury, those patients did much better. But in this paper, he recommended that ACL repair was unpredictable, and therefore the worldwide community at that point really kind of moved on. And the reason they moved on was because the old way of doing things, the open repair, which you see down here in the corner, and then casting the patient post-op. It was they tried to repair every single tear, no matter if it looked like the one shown here or if it looked completely intact. They tried to repair it, and it was about a 50-50 operation. There were a wide variety of ages. There was concomitant injuries. Oftentimes MCLs and LCLs were thrown into the mix. The surgery was pretty miserable. It was done open. It was arduous. It was lengthy, and the rehab was primeval. So we can see why they wanted to give up on this, because arthroscopy had come around, and they were excited about arthroscopy and doing things in a new and minimally invasive way. And so really repair was abandoned. And right around 1990, that was about the last that you heard of repair, except for some long-term follow-up papers. And since that time, there's been 30 years of evolution of ACL reconstruction. And you guys have watched all that on the MRIs and the x-rays, and you've literally watched the evolution of surgical thought go from screws to pins to absorbable screws to single bundle to double bundle, medial portal, flexible ream, and you've seen it all pass before your eyes on the radiology, in the radiology reading room. And as you guys all know, not everything worked very well. And quite a number of people who have had ACL reconstruction surgery ended up developing pretty serious arthritis. And so, you know, there's a hole in reconstruction and ACL ligament surgery, and we may be able to do it better. So we wrote this paper in September 2016, suggesting that maybe it was time that we looked really closely at the history and perhaps we perhaps altered it. We suggested that when they looked at the 50-50 results of open primary repair, that they looked at the glass as half empty and decided that it didn't work, and they threw the baby out with the bathwater. That they really took a detour on the evolution of surgical thought. And if they had only looked at the data and said, well, look, 50% of the people healed, let's figure out which ones healed, and we can do the repair surgery for them, and then we'll do the reconstruction for the others. If they'd only looked at it that way, they would have kept on evolving and trying to figure out how best to repair people. And we would be repairing people today. The trouble is they looked at it as the glass is half empty, and then said this doesn't work, and then just threw it out and did reconstruction for everyone. And so really there was a point where the evolutionary tree of surgery just kind of fizzled out, and that was it. Nobody really talked about it much anymore. The theory is that the ACL doesn't heal because the fibrin clot that sticks between the ends of the torn MCL, as you see on the left there, it doesn't hold between the ends of the ACL due to the aqueous environment of the knee. And that theory was put forth by Martha Murray and Kurt Spindler, who are leading the one of the Bear trial up in Boston. The trouble is that from other studies, we know that the proximal end of the ACL is highly vascularized and likely has a better chance of healing. In addition, and this is one of our studies, we just did quantitative gadolinium enhanced MRI on 5 fresh frozen human cadaveric knees and showed that the relative perfusion of the proximal ACL confirms the prior India Inc. studies. In addition, these biopsy studies by Nguyen showed that when they biopsy the proximally torn ACL that had scarred into the PCL, that the healing, the histology of the healing was very similar to the histology of the healing MCL. So in addition to that, we wrote this systematic review that divided all of the old papers ever written from 1950 to 2000. And we were able to divide them into papers that included mixed tear types. And then there was a group of papers, maybe 6 in all, that included only proximal tears. And what you find here, our data is in the red, there were the papers with all proximal tears, and they did statistically better in every category when they were compared to a group that had a mixed type of tears. And the correlation was so strong that you could actually draw a straight line correlation between how proximal the tear was and how well the patient did. So this shows that the old literature and the old way of doing things, even when you did it open, that it worked. It's just that it only worked on certain tears. I always say, you can't repair the ACL unless you're trying to repair a repairable tear. And that's where they got it wrong. So my suggestion for my ACL preservation is very simple. It's that the tear on the left, which is a complete tear of the ACL, behaves a little differently than the tear on the right, which is also a complete tear of the ACL, except it's simply avulsed from its femoral origin. And perhaps by using arthroscopic techniques, and this is one of my patients who had an internally braced ACL repair, perhaps we could do a more minimally invasive procedure, save the ligament, and still have better outcomes. But all of this requires you to go against the grain. And that's what I've done. I didn't realize that I didn't wake up one day and say, oh, I think I'm going to go against the grain. But what I was really doing was working in an environment that caused me to think outside the box. And I was working with my friend and colleague, Dr. Hilary Humans. We, at this time, worked up at a place called Jacobi Medical Center, which took care of predominantly a lower socioeconomic group of patients. And what I found out, I trained at the Hospital for Special Surgery in New York City, which is one of the ivory tower places, and very well funded and well-to-do folks. And what I found was that the patients, the surgeries that worked great when I worked on people who were on, let's call them the haves of society, didn't work so great when you did the same exact surgery on the folks who were the have-nots. And so taking care of lower socioeconomic group of patients really highlighted the healthcare disparities. And I found that ACL reconstruction patients didn't do as well as they did when I was training. And that caused me to search for better solutions. I gathered about 20 patients over 5 years, and this is the first talk I ever gave on this topic back in 2012. And I think I had to bribe the person to let me actually give the talk. And I certainly do remember crickets in the audience and people leaning across to their neighbors saying, is he really talking about ACL repair? And what I talked about at that time was, there's many ways to skin the cat with ACL surgery, and that can't we do better, because there's a lot of failures and arthritis and stiffness with standard reconstructions. And a one-size-fits-all approach to surgery, to me, seemed ill-advised. And I thought that perhaps we could come up with a multiple options. And so really all I was trying to do was fan the flames of the discussion, and maybe we could start a worldwide discussion and come up with some ideas. Because we all know there's problems with ACL reconstruction. There's a lot of atrophy in the muscle, and you can see here a harvested BTB. patella tendon, and that's a big hit to the knee right there. There's proprioceptive loss because we resect the entire ligament. There's 20 to 30% re-tear rates within 2 years if you include both the same knee and the other knee in the population under 18 years old, which you could argue that we should be doing the best in. There's a discouraging risk of long-term OA. The revisions are difficult, and certainly a one-size-fits-all approach doesn't make sense to anyone. So my suggestion was that the same old thinking just results in the same old thoughts. You can try and come up with 100 new ways to reconstruct the ACL, but if you keep chopping out the ligament, then there's a lot of better ways to do it, in my opinion. Essentially, what I'm suggesting is that we could pick the low-hanging fruit off the ACL tree. The 50% of the people that healed in the past are those people who likely had proximal tears that Dr. Sherman taught us about, and perhaps we could do a smaller operation for those people. Well, it seems like the idea is catching on. I call this past 18 months the year of the systematic review, because all across the world, people have jumped into this conversation, and there has been no less than 10, probably 12 systematic reviews on the topic of ACL primary repair. Essentially, there's 4 different ways that are being done currently. There's my way on the upper left using suture anchors. There's a variation of my way published by Dr. Wilson and also Dr. Mackay and Dr. Dewigi, and that's using an internal brace to hanging off of buttons top and bottom. There's this procedure on the lower left, which is done in Germany, which is based upon burying a spring into the tibia that they attach the repair stitches to, and that spring gives it some give, and they call this the dynamic intraligamentary stabilization, DIS procedure. And then finally, there's the Martha Murray camp up in Boston, and they have a different approach where they place a collagen-soaked sponge in between the ends of the torn ligament. They're focusing more on the mid-substance tears of the ACL, and so they try and capture the blood clot by placing a collagen-soaked sponge, and they've been also doing some research for quite some time, and they have a government-backed study going on their technique. So those are the 4 ways of doing it. One of those systematic reviews was done by my friend and colleague, Dr. Sonnery Cote in France. They looked at 19 studies, 1,000 patients, 5 of them comparative, and they were trying to see if there was any benefit to primary repair, if they could compare it to reconstruction, and they were looking for longer outcomes. And they focused on arthroscopic outcomes and arthroscopic papers, because if you include the old open papers, those muddy the waters because they include data on all types of tears. And what they found was that in the published literature on 1,000 patients, there's really no difference between primary repair and reconstruction when you're looking at patient-reported outcome measures, objective measures, activity levels, or laxity. And there are a handful of papers that report out to 80 months, showing Lysholm scores between 85 and 100, IKDs the same, and Tegner's are reasonably well. And the conclusions are that the outcomes seem pretty similar between repair and reconstruction when done selectively. But as with all research, in the beginning, the numbers are small and the follow-up is short. This takes us to my group's study. We looked at 13 studies, 1,100 patients. However, we tried to focus in only on arthroscopic repairs that were done for proximal tears. We divided the group into those that used no type of augmentation, simply suture anchors, per se, those that used static augmentation, which adds an internal brace to the construct, and then those that use dynamic augmentation, DAR, and that was focused on the group that put the spring in the tibia. We found that all the functional outcomes were high over 85, and the failures and reoperations varied by type. The outcomes are promising, but more data was needed. And if you look closely at the data, what you'll find here is you focus in on the lower right, that the failure rates overall are about 11%, the reoperations about 9%, and then the removal of hardwares were focused mainly on the DIS group, and that was about 1 out of 4 patients. And you can focus in there and see that the DIS patients have quite a few more patients than the other groups, but they also have this disturbing 1/3 of the patients have to go back for a second operation to remove that spring out of the tibia. So that's one of the limitations. Let's get to my techniques and how I indicate patients. You know, I use suture anchors, kind of like a rotator cuff repair. When I was first doing it, I started coming up with this. I called it the rotator cuff repair of the knee. And it's simple, intuitive, and it works. It's technically straightforward. It's very minimally invasive. We use biologically vented anchors that allow the bone morphogenic proteins to come out of the wall. It's biomechanically sound and puts the footprint right back where it should be. We save the nerves, the blood vessels, and it's easily converted to a reconstruction if it happens to fail. The technique's been published many times in these several journals. This is actually how I do it. This is one of my first 25 patients. You can see that's a nice proximal tear of the ACL, although I know you guys are not used to actually looking intraoperatively, but this is the ACL sitting there. The large bulk of the ACL is intact, and I'm putting in a locking stitch of that striped suture called tiger wire. We're going to put another one into the posterolateral bundle now, and then we're just going to anchor them up to the wall with these suture anchors. This is a 40-year-old patient who tore his ACL in jiu-jitsu practice, and that's the ACL now repaired directly to the wall. This patient's about 5 or 6 years out now, and he's been doing amazingly well. About 30 or 40 patients into my experience, the technology called the internal brace came out. And really what it is you can think of it kind of like a stout shoelace, and it's the blue here. And what we did was we added it to the construct, and we pull it down along the ACL after we've repaired it and attach it down to the tibia so that it reinforces the ACL. And so that's called an internally braced ACL primary repair. With Arthrex, we've now come out with a kit that includes all of the implants and equipment that you need to do this. So it's getting easier and easier for surgeons to apply this technology. So my approach I call ACL preservation. It's not a binary approach, which is the standard ACL reconstruction approach, where if your ACL is torn and you're athletic enough, they say, okay, you get a reconstruction. And if it's not, or you're not athletic enough, they say, no, you don't get a reconstruction. Mine is a little more nuanced. I published this topic called preservation. It's a treatment algorithm based on tear, location, and tissue quality. And I published it in these 2 articles, and I'd like to describe it to you. It's based off of the remnants that we find on the MRIs. And we published an updated system of a classification system, which goes from 1 to 5, which I'll describe a little bit more completely later. So if if I'm going to operate on the patient and the patient has good tissue and it can reach the wall, then we'll do a primary repair. If they have good tissue, but it's not going to reach the wall, I'll primarily repair what I can and then add a graft to that. And we call that primary repair with augmentation. So we save the remnant of the ligament. They tried to do that in the past, but they got into a lot of trouble with that because the ligament remnant would slide down the ACL, create a ball in the front of the knee called a cyclops lesion, and that would prevent full extension, and they'd have to go back and operate. However, when I put stitches in that remnant and tie it up to the fixation, then the remnant doesn't fall down, so we don't really get cyclops lesions, and we can benefit from saving the nerves and the arteries that are in the remnant. And finally, as a last resort, I will, if there's no tissue left whatsoever, then I'll just do a reconstruction. So I use reconstruction as my last resort, whereas most of the other docs out there use reconstruction as the only resort. So here's some pictures of remnants that I would repair. These on the left here are nice long primary repairable remnants. These are type 1s. And now here, these are a little shorter. These would be ones that I would repair and augment, and something like this in the center, which is kind of frayed and frazzled, we would probably resect and reconstruct. This is an example of a primary repair with augmentation. You can see that initially you could see the graft that was sitting in there, and then I pulled the ACL up around the graft. So that's the native ACL tissue that I just pulled up, and now you can't see the graft anymore because it's literally inside the graft. Here you can see a different patient. You can see the white of the graft in the lower right that we're probing, and the remnant is in the front of the graft that's been tensioned. Now look distally here as I stroke the vasculature with the probe, and you can see the nice capillary refill coming up, which is showing you very plainly that that remnant is very much alive, and it will help us to scar in the graft. So we published this paper to see which patients were more likely to get repairs. We looked at 361 patients and found that over the years we had repaired 44% of them, or 158 patients. After multivariate analysis, we found that age over 35 was very predictive of having a repair. So over 35 patients tend to tear their ACLs off the bone. Also, if we got you in surgery within 4 weeks, we are more likely to be able to repair it. And if your BMI was lower, you tended to have a more proximal tear. We published this MRI classification system. Type 1 tears are over 90% up the ligament. You can see them on the upper left here. And we found that 16% of this group of patients, which is, I think it was 350 patients, had type 1 tears. Type 2 tears were proximal within the top 25% of the ligament. 27% of the patients had those. Type 3 tears were in the mid 50% of the ligament, and 50% of the patients had those. So if you look closely at this, 43% of the patients had type 1 or 2 tears, which are the ones that we can usually repair. We also performed this study in the pediatric population, and you can see this is all divided based upon age. In the very low age group from 6 to 10, it's mostly bony avulsions, and 11 to 13, it's kind of an in-between, and 14 to 17, it's approximating more of a normal adult distribution. We looked at this study here, published recently, and when we looked at the MRI, we measured the distance of the remnant, and we found that if the remnant was over 75% of the length of the ligament, that our ability to repair it was 94%. And again, we noted that older age was correlated with a more proximal tear. This was a paper we published trying to figure out if we had a type 1 or type 2 tear or type 3 tear, what eventually happened with the patient. Because I would, whenever I describe this surgery, I tell people that, yes, the MRI gives us an idea, but it really matters what it is like when we get into surgery. And basically, this is asking us if MRI tells us a lie or not. So of the patients with type 1 tears, we were able to repair 88% of them. Of the patients with type 2 tears, we were able to repair almost 50% of them. And type 3 tears, we were able to repair 12% of them. And I'll let you know why that is in a second, because I know some of you are scratching your head saying, didn't you just say that type 3 tears were unrepairable? And the answer is yes, I did. But on MRI, some type 3 tears are actually folded over type 1 tears. And I'll show you an example of that in a moment. So here we are now, that paper was one of the early papers we wrote. Now type 1 tears on MRI, I can repair 99% of the time. So if I see an MRI like this with great tissue, this looks like this when we get into the operating room, and you can see the ACLs coming off the wall. I can repair this one 99% of the time. And there you see a nice primary ACL repair. Type 2 tears, we can repair about 50% of the time. And you can see this tear that it ends, it's roughly 75% of the way up the ligament. And this one looks like this on, when you look in there. This one is kind of like the troll doll when you spin it. It's the top of the ligament has splayed apart, but the bottom of the ligament is intact and has its synovial membrane. You can see here when we tuck it back in, it looks a lot better. And after we're done, we tie that one up, and it's this patient healed nicely. She's about 6 years out. Finally, this patient here, type 3, I said it's about 15 to 20% right now. And what I'm looking at in this MRI is here that I can see that portion of the ligament is folded over. And when I look inside the knee, here we see the PL bundle, which is rather diminutive. But here's that folded over portion. And if we push it back into the notch, we see that it's quite robust and it's quite a lot of tissue. Excuse me, I gotta wet the whistle. Now, if we hold it up, you can see it's starting to look like a normal ACL. and we put stitches in it and anchor it back into place. And this patient did extremely well. Here you can see a follow-up MRI showing that the native ACL is running in the correct direction and it's nice and taut. At 2-year follow-ups, the patient had absolutely no symptoms. He was functioning extremely well, and he only had 1 millimeter side-to-side difference. So my results from this, my early results, this was the first paper we published on the early results, showed that that 10 out of 11 patients were doing great at minimum 2-year follow-up. This is a very controversial paper because many surgeons told me that it was simply a matter of time until they all failed, because that's what happened to John Fagan back in the day, is the 2-year results looked good, but the 5-year results were very poor, which gave me great pride when I published this paper showing that actually the 5-year results showed no deterioration whatsoever, and 10 out of 11 patients were still doing great. Now, the question is whether or not to use an internal brace, and we had to get our numbers up. Well, as time went on, more and more patients found me. This is a follow-up on 56 patients with 2-year follow-up. 29 patients had no internal brace, and 27 had the internal brace. And it showed up there was no statistically significant difference between the bracing patients. However, there was also no negative effects with the internal brace. And we had 6 patients re-rupture for a total re-rupture rate of 12, and with 4 of them had no internal brace and 2 of them had internal brace. And the patient-reported outcome measures were excellent across both cohorts. This paper we just recently published, again, the numbers keep going up. This is 113 patients with minimum 2-year follow-up. And what we were able to do in this paper was the first time we were able to divide the patients based upon their age groups. And what we found was in the over 35 group, which was the largest group, 62 patients, only two patients failed for a 3% failure rate. In the 22 to 35-year-old group, we had 24 patients, 1 person failed, 4% failure rate. However, in the under 21-year-old group, we had 10 out of 27 fail for 37% failure rate. And while this number is quite high, the number of the failure rate in teenagers with reconstruction is also quite high. It's not quite this high, but it's very concerning. And so, it's the importance of research. If you come up with some untoward results, you need to report your negative results too. And so in this younger group, we've begun to place an augment graft in with most of those, since the failure rate's too high. We looked at failure and reoperation rates from between repair and recon, 91 repairs versus 93 mixed recons. And we found that the failure rates were roughly similar, 12% for primary repair and 15% for recon. Now the recon failure rate is a little high. It's because the follow-up wasn't as complete with that group as it was with the repair group. And also this is a very mixed group, including all types of grafts and some chronic tears. This paper we also just published, and this looks at whether or not you have to get the patient to the operating room acutely within 4 weeks. We looked at 39 patients who got to the operating room within 3 weeks, and 37 patients who got to the operating room after 3 months. And long story short, the failure rates, there was no statistically significant difference between the failure rates in both groups, which shows us that it's really not the amount of time that passes between when you're injured and when you get the surgery. It's more important that you have appropriate tissue quality and length. And I do have one published paper on an individual who was 11 years after ACL tear. At that point, he tore his meniscus and bucket handled it. We went in, repaired his meniscus, and we also repaired his ACL because it was scarred to the PCL. We were able to clip it off, reattach it, and he did great and had a stable knee 11 years after injury. Again, this is the acute versus chronic, showing no significant difference. And so my results to date, we've done up to over 325 cases of just isolated ACL tears. If you include the multi-ligament tears, we're closer to 400. We try and keep it specifically to type 1s and 2s. And we have mostly internal brace. I started using that exclusively about 5 years ago. And we're running at around 90% overall clinical success rate. Again, I mentioned that there's a higher re-injury rate in teenagers. So if we exclude them, the failure rate drops. The return to sport data that we've published recently is very similar to the reconstructions. The overall return to sport is about 85% to any sport. For knee strenuous sports, it's 70%, and the return to the pre-injury level is about 60%. These numbers actually may even be a little higher than ACL reconstruction. And here we see the time to return to play. And the amazing part here is that close to 40% of the patients were back playing within 6 months. And now with reconstruction, it's usually 9 to 12 to 15 months to get them back to play because of the morbidity of the procedure. We know that repair is dramatically less morbid than reconstruction. You can see the harvest site for a patella tendon on your right, and you can see the patient with nearly symmetric quads on your left who's 6 weeks after an ACL primary repair. You can see the minimal incisions that have healed compared to that approach for the patella tendon. We know that patients did much better, and that's what prompted me to keep doing the operation. So we published this paper to try and show that. We know that patients have usually at least 30 degrees more range of motions at the first visit, and they hit full range of motion much quicker. In addition, the excuse me, the internal brace has no effect at all. Whether or not you include it, it does not affect the return of range of motion. And then finally, the complications. We can see here, we didn't have the numbers to find statistical significance, but what you can see here is there's a lot of zeros on the primary repair side, and there's not a lot of zeros on the reconstruction side. And so, and that's what we find is that reconstruction has a small amount of a lot of complications that add up, and repair has very few complications. We've also performed this this study and published it in the Journal of Arthroscopy, looking at the awareness of the joint. When you do a repair versus do a reconstruction, we wanted to know how much more often you're thinking about your knee with one surgery versus the other. And what we found was that healthy controls scored about 88 on this metric, and the repair patients scored 85.3. So they scored nearly the same as healthy controls, whereas the reconstruction patients scored 74.5, which was the minimum, I forget what MCID stands for. I'm not going to struggle with it. It's the minimal clinically important difference. That's what it is. But anyways, the 9-point difference is minimally clinically important difference, and this was over 10 or 11. So patients think about their ACL reconstructed knees far more than they do about their ACL repaired knees. To give you an example, this patient here had ACL reconstruction 24 hours ago, and he had no anesthetic blocks performed, and he's taken no pain meds. And for those of you out there who've had reconstruction, you'll know that that was not your experience. This patient here is 6 weeks post-op. She ran a half marathon at 3 months post-op and scored 77th out of 3,000 people. She's about 4 years out. This girl here is 4 months doing a tumbling run. I'll be very transparent and tell you that about 2.5 years after her surgery, she landed wrong on a twisting backflip with all her weight on one leg and retore it. Ultimately, she underwent a reconstruction, and she did well after that. And this patient here, you see her run. She's 4 months post-op. And the amazing part about this is she had simultaneous bilateral ACL repairs. She fell skiing and hit 2 trees, and she tore both of her ACLs. We did them both at the same setting, and this is her running at 4 months. Absolutely a miraculous recovery. You could never do this if you were doing reconstructions. So back then, in the beginning of the talk, I talked about thinking outside the box and how taking care of different groups of patients with different needs led me to thinking outside the box. I usually say, if you don't go outside of the box, you never think outside of the box. I suggested that there's many ways to skin the cat with ACL and ligament surgery in general, that maybe the ligament on the left behaves differently than the ligament on the right, and perhaps there's a place in our armamentarium for repairing and saving the tissues. I think that we should have a multifaceted approach for ligament surgery of the knee, and that there should not be one size fits all approach, and we should have multiple options at our disposal. I like to think of a Swiss Army knife like this with hundreds of tools, and that's what our surgical bag should look like. I think it is possible to pick the low-hanging fruit off of the ligament injury tree and do a more minimally invasive surgery for them. This is the thing that I'm trying to avoid. This is called the innovation distribution curve. And essentially, if you look closely, the innovators are on the far left, the early adopters are on the rise. And then the trouble is when everybody jumps in and starts to do the surgery and they have poor indications and don't pay attention to the technique, then you get the chasm of discontent. I'm trying desperately to share my data, my experience with the world so that people can avoid this chasm and our patients don't have to suffer. It's very important that we concentrate on indications and technique so that we can make this a successful part of our armamentarium going forward. So what's a radiologist to do with all this information? I think one of the important things is that just saying that the ACL is torn, it's really no longer enough. And that I'm sure that you guys don't, I know you're very, I know from following the OCAD posts that you guys are very academic and you're very into staying up with the latest developments. But I can't tell you how many reports that I see out there where they just say that the ACL is torn. It's important that we know where it's torn, how it's torn, whether there's displaced fragments, et cetera, et cetera. Certainly, I look for all of those when I'm reading the MRIs myself. I would suggest that you challenge yourselves to be with us on the cutting edge of surgical evolution and help us to see. That's what you do so well. Continue to help us solve the injury puzzle through collaboration. And you can see on this page, here's 7 articles that I've published with various other radiologists on all different topics of how the MRI can help us to both diagnose repairable tears, to predictably measure and predict which ones can be repaired, to follow the healing of the ACL, and here's another article on the top left. I think I provided this one to you guys. It kind of goes through the topics that a radiologist should know. So the goal of my original talk was to fan the flames of ACL, the topic of ACL repair surgery, and all over the world, this is becoming an interest for people. We did this survey of the European Society for Sports and Knee Surgery. 169 surgeons responded, and 70% of them thought primary repair was a reasonable option, and fully 38% of them used primary repair in their practice. So I do believe that we have. We are making progress worldwide with this topic, and all over the world, people contact me telling me that they've had my experience, their experience is the same as mine. So welcome to the future. I think it's going to be exciting as we try and save more of the human body, and we harness the biological power of the body to help to heal injuries. The whole goal of all of this is to make things better and not simply relive history. And I want to thank my research team who've really done a yeoman's work in publishing over 40 articles in the past 5 years on this topic. So thanks for your time. If you feel like following or along with the story, you can follow me on Instagram. You can see me on Twitter, Facebook, and LinkedIn. And always happy to talk about this with any and everyone.
Greg, that was fantastic.
Happy to take questions.
Yes. There's a question in the chat from Dr. Kalia. is asking for a clarification. What are the key features and descriptors you like to see in descriptions of the ACL on MRI?
I think the location of the tear is critically important. Proximal third, mid third, distal third. The organization of the fibers, whether the fibers are running in roughly the appropriate direction of the native ACL, because oftentimes that tells me that there are a few fibers that are still attached, and if that's the case, then it tends to keep the ACL running in the right direction, and it tends to keep its length, as opposed to if it's pulled off the wall and flipped forward. If you don't get to it quickly in that situation, then the ACL tends to curl up like the Wicked Witch's legs. So position of the tear, the direction of the fibers, whether it's stuck to the PCL, if it's out of plane, if it's sagging, and the amount of high signal within the ligament. You know, when I was taught back in the day, I was taught that, sometimes you see what you guys and many people call a ghost ligament, where you see the ligament fibers, but it's very, very heterogeneous in signal because there's a lot of edema in the ligament. And what I've found over the years of operating and being very keenly aware of these things is that that doesn't mean that the ligament's destroyed. All that means is that there's a lot of edema in the ligament. And I've been able to repair those people, put stitches in that body of the ligament, pull it up, and then you check them, an MRI in 6 months to a year, and all that edema is gone and the ligament's back and it's black again. And so it's very interesting watching how the edema patterns progress. And in fact, one of those papers, we talked about it, how it takes a while for that ligament to mature and remodel over time.
That is interesting. Tim Murray asks, do you ever manage acute, complete, non-displaced, or high-grade partial thickness tears conservatively? He adds that they've seen a few patients with this come back for repeat MRI for various reasons, with essentially normal-looking MRI a few months out.
Yeah, so that's a great question, and I love talking about this because it really brings you right into the crux of the problem. The decision matrix of the surgeons, and more importantly, the family and the patients, right? Up until this point, it's a binary decision. You've got do a big surgery or do nothing. And so if you have a partial tear and the knee is loose on exam, you're hoping that that knee is going to somehow tighten up and that things will heal. Or the answer is chop it out and put an entire graft in there. And to me, those seem very extreme, right? Well, my surgery fits in right about here. It's do a small surgery with very minimal morbidity, with a very quick recovery, with little downside risk. So if you have a partial tear, I can go in and put a couple of sutures in and tack it and tighten it back to the wall, and the looseness of your knee is gone immediately. I don't have to wait and see if it's going to tighten up. I'm going to tighten it up for you, and now it's going to heal right the first time, right? And so that is my answer. I think there's a lot of partial tears. And yes, if you follow enough, you're going to find some that will come back and have a tight knee, a normal exam. And we all know about those patients. They're probably the patients that have 50% of the fibers sitting attached, and it's only half torn and it didn't retract. And if you keep them and go slowly, hopefully the rest of the fibers will scar in. But to me, I can accomplish that goal with a very, very minimal surgery. Fully a third of the patients that I do this surgery on take 0 pain pills. And 90% of the patients are off pain medicines in 2 days with a total of 5 pills or less. So when I say this surgery is a different animal, this surgery is more like a meniscectomy than it is an ACL reconstruction.
Hamza Alizai, who is actually at Texas Scottish Rite, is asking, why do you think the failure rate is higher in the adolescent population?
That's another great question. And God, I wish I had answers for this. It is a multi-headed hydra, right? I think that if you tear your ACL when you're an adolescent, you've declared yourself that you have high risk factors for ACL injury, right? So we see a lot of kids coming in, young ladies with knock knees, with hyperextension and very lax joints. And so these people who are they're not quite fully mature yet, and yet they're out there playing soccer on 3 different teams 12 months out of the year. And so I think that there's a group in that young group who are predisposed to tear their ACLs. And I think that's one of the reasons we see high failure rates even with reconstruction. And so what's happening with single sport specialization, with overtraining, right? People playing on 3 different teams every single season of the year, the exact same risk factors for the whole year, and it's all exaggerated and injected with steroids, then those are the people are getting injured. I mean, I always say to the parents, I said, riding a motorcycle is fun. I like riding a motorcycle. When I lived in Colorado, I rode motorcycle. You didn't have to wear a helmet, let the wind blow through your hair. Back then I had nice, long, shaggy mane of hair. And I wasn't worried about it because I was out in the mountains of Colorado where there weren't many people. And now I say, I want you to ride your motorcycle every single day, commuting into and out of New York via the George Washington Bridge every day of the year, and tell me how long you make it until you get clipped. And that's really it. It's cumulative risk, it's predisposing risk factors, and it's all creating this witch's brew of an incredible amount of ACL injuries in the young people, and the surgeries it's more difficult to get them through it, and to get them to a point where they can compete at these high levels. So it's a very, very complicated topic, and there's just shit tons of data on it. We could talk for hours and hours and hours just on that one, but that's a couple of the reasons.
On the flip side, we know about the failure rate on the kids, but I think was it over 35 that does quite well? Was that the old person age?
100%.
Okay, so I know when it comes to other orthopedic surgery, people in our age range, I mean, we're just on the junk heap, right? So how old is too old?
Well, how old is too old becomes a very, very critical question when you're doing a big surgery like a reconstruction.
No. So I'm asking about primary repair specifically.
And my point is when you're doing a low morbidity surgery that's more like a knee scope, the oldest patient I've done it on was 72. Now, I agree with that. When I was looking in the mirror and saying to myself, are you really going to do an ACL on a 72-year-old? And my answer was, this 72-year-old was a ski instructor, a tennis instructor, played sports every single day of the week. She was like a 30-year-old. And she tore her ACL right off the bone. And she wanted to go back and do all these things. And I said, well, I'm not going to reconstruct you, but I will tack it back and then see how you do. Because really, I think about this surgery, and I don't really, I know it's a little self-serving. And like I said, I started it off with I'm biased, right? But I don't really think of it like a surgery like reconstruction. When you tear your ACL, the fibers are pulled, they're disorganized, they're unkempt, and your body's trying to heal them. And really all we're doing is we're bundling up the fibers and putting them into the position where they were, and then just let the body heal it, right? And we find that in multi-lig knee injuries, I didn't include my research on knee dislocations and repair, but there's also, it works incredibly well for that population too. And the point is, if you get in there early, if you organize the tissues that have been destroyed and you put them in with internal braces and move them quickly, no casting, then what you find is that the body will knit everything back together in a much much more predictably than in the past when we used to cut people open with 10-inch incisions and then put them in a cast for 2 months.
So Vivek Kalia, apropos, when you say if you get in there quickly, he's asking, what's the ideal time to image by MRI after the acute injury?
Immediately. Immediately, as soon as you can get them. And I get into this topic all the time when I'm talking to docs who practice in countries that have national health services, because they say to me all the time, Greg, I never see the patients until 9 months to a year. And that's why we published that one paper that showed there was no difference if we got to them within 3 weeks or 3 months, or after 3 months. It really matters about the tear type. But I think optimally, if you injure your body, you should try and get imaged immediately and quickly regain your range of motion and get on the table within the first 4 weeks, so that we can rearrange things so that the body can heal them correctly the first time around, not the second time around. My
I got a
point is,
question. You said that some of the what are perceived of as type 3 on MRI actually turn out to be type 2 in disguise and
Yeah.
amenable to repair. Are you ever surprised the other way around, where you think something is definitely a type 1 or type 2 that turns out to need a recon?
well, that's occasionally I'll get in there and the tissue won't hold together. And I had one of those, the 1%. I had that about 3 or 4 weeks ago. And it was I had a day with three ACLs on. The first 2 we repaired, and then the last one, which I thought was going to be the slam dunk one, we put the anchors in, and then I went to tie a knot, and the anchors pulled out, and her bone cracked. And it was she had very, very weak bone there, and so they wouldn't hold the anchors, which was odd, and it's the first time I had encountered it. But at that point, we just switched it to a recon. So I go in for every patient with the plan of repair it if I can, augment it if I need to, and only reconstruct it if I have to. And that plan works for me. Patients understand it. I'm going to save as much as I can if I think it's in your best interests. If I have a Division I 17-year-old Division I soccer athlete who's going to go to college and play on a scholarship, I'm going to put a graft in there to augment it. If I have it doesn't mean I don't do repairs on any teenagers. I had a girl who was a 15-year-old who slipped. She was a diver and she slipped on the side of the pool. I mean, that's just bad luck, right? I mean, she doesn't have a high risk life for ACL injuries, and she tore it right off the bone. So we repaired her. But the cutting athletes who go right back into harm's way, those they might need a little more. So I tend to put a graft in there with the ligament.
So what changes between age 34 and age 35 is what you're doing for fun?
Yeah, I don't think that's the answer, Hillary. I think the answer is very plain. I think it's all has to do with the blood supply. And just like at the rotator cuff, when we talk about the watershed area and that the watershed area fades, and that's why the rotator cuff always tears right at the bone. And that's why your quad tendon always tears right at the bone. And that's why your Achilles tendon tears at the watershed area. Uh-huh. And all around the body, the same exact thing happens. I think as we get older, our vascularity fades a little bit, and all of those junction points, they lean more towards catabolism versus anabolism, and eventually they pop. And what you find is that skiing is it's like putting a giant corkscrew on your foot, right? And so you catch your edge, and now the ski has leverage, and it just pops the ligament right off the bone. And those are not the injury mechanisms in the teenagers. It's a very, very different injury pattern.
So in reporting, it makes no difference to you if it's an actual avulsion at the bone or it's proximal third. It's
really proximal quarter. It's within the top 25% is like I like to see. And like I said, in that one paper where the remnant length predicted whether we could repair it, if the remnant length is over 75% of the combined length, then we were usually able to repair those.
Of the combined length, what do you mean?
So if you measure the remnants, the stubby on the top,
Oh, the
and
stubby on both sides.
right. So we tried our best to, measure what the combined length of the ligament would be. And if the bottom part is over 75% intact, then we usually have a pretty good shot of repairing it.
Interesting.
I'll throw in a couple more things that I find very fascinating. And I think this is a great topic for you guys in the radiology world, the MSK radiology world, to chew on, is that, the gantry, I think that's what you call it, right? Or the line of probing for the MRI is set to look for the ACL where it normally is, right?
Right.
What are the technical words for, it's not the gantry, is it?
The plane of imaging?
The plane of imaging.
Yeah.
So the plane of imaging is set to look for the ACL where it normally lives. And what I'll tell you very plainly is that when that ACL pops, it moves more centrally and moves towards the PCL. And so when you're looking for it where it used to be, a lot of times you'll cut the ACL in half because your plane of imaging is looking that way, when in reality the ACL is pointed that way. And so
I'm not sure if everyone is obliquing their sagittals to be in plane with the ACL anymore. I think we're doing straight. I mean, at least I think I know that my group does straight sagittals.
Well, it's interesting because I see a broad variety of MRIs from across the world, because people fly in from all over for me to do this procedure. And so I see a big variety. And sometimes, the way the plane of imaging is, it cuts it wrong. And I've seen people where I think for all the world I'm going to get in there and not see a repairable tear. And then I get in there and the damn thing is sitting right there asking to be repaired. So that's just a theory I have, and it's probably a very naive one when it comes to imaging, because I'm one of those, sawbones guys.
That might be it. That was really a lot to think about. Those images were very compelling. I find it all very interesting. Thank you for sharing all of this with us.
I appreciate the invite, and thanks for all the good work you guys do.